Welcome, everyone. I am Melody Brown-Berkins. I'm the director of the Institute of Arctic Studies in the John Sloan Dickey Center for International Understanding here at Dartmouth. And it is my absolute pleasure to welcome the folks here in the audience, folks on the web, and this incredible group of researchers here to Dartmouth today, and as well as many of you in the audience who are part of a workshop, a three-day workshop of visitors from all over the world working on issues of Arctic health. And it's really, again, such a pleasure and honor to host everyone, and now to be able to hear of the work that's going on. And because we have quite a full list of presentations, I'm going to go right into it and let you know what you're going to hear today. This is COVID-19 in the Arctic, a community perspective. And this is a workshop and work that's being done by a group because Arctic communities are implementing complex public health measures to limit the spread of COVID-19, and not only working with, of course, Western science and dialogues, but also with Indigenous knowledge in this process of understanding the impact on communities. The group here came together to specifically look at this. It's being funded by the Canadian government and being led by, or at least one of the key leaders of it, I will say there's many leaders in this group, is Dr. Gwen Healy-Akerloch, close, I hope, who will be our first speaker. But what we're talking about today is that in the circumpolar region, communities have and continue to rise to the challenge of implementing complex public health measures aimed at limiting the spread of COVID-19. To fully understand the implications of COVID-19 in the Arctic, diverse data sources are needed that include Indigenous knowledge and local knowledge with Western scientific methods. Identifying community-driven models and evidence-based promising practices and recommendations are key to informing Pan-Arctic collaborations and decision-making in public health during times of global emergencies. So this circumpolar team came together to address this issue and ask several questions, which I won't go into right here. I'm sure they're going to come up as the panel speaks. But there were things about how do public health measures are they implemented to address COVID-19? Are they same or different in Arctic communities? How have Indigenous knowledge and local knowledge been integrated with recommended and mandated public health measures to address the COVID-19 pandemic? What coping strategies did Arctic communities engage in? And what can we learn from the community case studies to inform policy and program implementations, not just in the Arctic, but around the world in the future, in my opinion, not just the Arctic. So first, we'll hear from Dr. Gwen Healy-Akerloch, who was born and raised in Iqaluit, Nunavut, where she continues to work and raise her family. Dr. Healy-Akerloch, and I'm going to keep working on it because I'm going to get it, is the executive and scientific director of, no, it's such a wonderful word. You'll help me. Qaliarctic Health Research Center in Iqaluit, Nunavut. She's also an assistant professor at the Northern Ontario School of Medicine and an associate professor in the Faculty of Medicine at the Memorial University of Newfoundland and Labrador. She was a visiting scholar here as a Fulbright Arctic Initiative scholar in 2019, as well as part of our Lancet Commission on Arctic Health that is being done, co-chaired by Dr. Lisa Adams at the Geisel School. Oh, hello. And Dr. Daly Sambodoro. Small world. And she was a member, and she's currently here at Dartmouth, most importantly, or one of the many important things, as a distinguished 2023 Fulbright Canada Research Chair in Arctic Studies. We are very lucky to have her. Joining her are Dr. Arja Rautio, Vice President of Research at the University of the Arctic and Professor of Arctic Research in Thule Institute, University of Oulu. She's been working in the field of circumpolar health and well-being, marginalization, research ethics, and human and environmental relationships since 2006. We also have Dr. Lara Johansdottir, is a professor at the Faculty of Business Administration at the University of Iceland. She is also a member of the faculty in the Environment and Natural Resources graduate program and interdisciplinary program under the School of Engineering and Natural Sciences. Dr. Katie Quetta, raising hands, was born and raised in Alaska, like me, we haven't talked about that yet, and works in partnership with Alaska Native and American Indian communities through participatory action research. She studies social determinants of health in the circumpolar north, culturally appropriate health promotion, advancing health equity. She's an adjunct assistant professor of public policy and health at the Institute of Social and Economic Research, a CDC CSTE, don't know what that one stands for, Applied Epidemiology Fellow in the Alaska section of Chronic Disease Prevention and Health Promotion, and associate faculty at the Johns Hopkins Center for American Indian Health. Finally, Dr. Christina Larson is here, is a sociologist by training and completed her PhD in public health. She is the research director of the Center for Public Health in Greenland, based in Copenhagen, and responsible for the research-based consultancy for the Greenland Ministry of Health in the government of Greenland. She's a PI for the Greenland Health Survey, conducted for the Ministry of Health every 4 to 6 years. Dr. Larson was a Fulbright Scholar and part of the second Fulbright Arctic Initiative cohort as well from 2018 to 2019. And I should mention one of the co-lead scholars for that initiative is also here, former Institute of Arctic Studies Director and distinguished professor, Dr. Ross Virginia in the front row. So we have quite a wonderful group in the room here, and I am going to now turn it over to the first of several presentations. You're going to hear from this group as they work through these ideas and prepare essentially a very policy-relevant, critical research for the future of public health in Arctic communities. Thank you. Okay, I'll give you, I'm going to come up, you'll see me in between changing slides, but other than that, you can ignore.
Okay, Priyanamik. Welcome everyone. Gwen Hilia Kiaro Yunga, Ikalung Mitao Yunga, Isumiltui Yunga Kawigartid Nunavumi. So I'm Gwen Hilia Kiaro, and I come from Iqaluit, Nunavut. I'm as Melody said, the executive and scientific director of the Kawigartid Health Research Center. And I'm going to share a little bit with you about some of our early research exploring the experience of COVID-19 in Nunavut. So I think I have control. I won't repeat what Melody said, but I'm formally trained. What we say is I'm formally trained as an epidemiologist, but I'm heart trained by Iqaluit, who have taught me all that I know and what I continue to learn about well-being in our communities. And I've been working in this sector for over 20 years. A little bit about Kawigartid. We're an independent community-led research institute. We work to answer the questions of our communities, and we sort of grew out of a climate of helicopter research coming in and out of our communities and data leaving and not being able to access it. And so we are run by Nunavummiut, and we hold the data locally, and we use it for action, hopefully, in different ways. This is not meant to be in here. So I think the wrong slide. I'm going to skip ahead, but isn't this a beautiful day to go out on the land? This is all about a presentation about community well-being and all of the aspects that we see feeding into our well-being, from harvesting to relationships with the land and our elders and our community members who learn from each other in the spaces we cultivate, our young people who are part of not only our governance structure, but in terms of telling our institute what to do, but also meaningful participants in our projects and programs. And all that to say that our institute builds on the strengths of our communities, and we work to release the capacity that is already there that our systems don't traditionally access. So we're lifting up the ways of knowing and being in our communities that are health promoting pathways. And the framework for our research around COVID and for any project really at our institute is based on the concept of Piliriqattinginuk, which is working together for the common good, that we are all working together for the collective benefit of Nunavummiut. And the bigger model focuses on values as a framework instead of themes or other sort of traditional research frameworks. Our research framework is based on these guiding principles related to Unikaqattiginuk, which is storytelling, Iqaumaqattiginuk, which is thinking deeply until we come to a place of understanding, being good and compassionate and respectful of our shared humanity. This is what the model looks like, and it's published if you want to find it. It's open access. And so that's the approach we've been using to look at COVID in our communities. This is a terrible slide that I will find a better way to present at some point, but basically the timeline for COVID in our communities was we went into the lockdown, the public health emergency order on March 20th, 2020, but COVID didn't actually arrive in Nunavut until later in November 2020. So we were able to delay the arrival of COVID due to a travel ban largely, but also pretty strict public health measures. And then the vaccination program in 2021, and then my community had its first outbreak in April 2021, so much later. And then the restrictions were lifted last April, and the proof of vaccination for travel requirements changed in the summer. So our timeline looks a little bit different. That's the only point of that slide, really. And so when the outbreak first started, we started collecting data from all sorts of places. Like, the benefit of being a community research institute is that we saw right away what we should be looking at and collecting information about. And so we were working with organizations to understand the impacts on them as community serving organizations, how people were sharing food, and then kind of looking at different ecological data sources. Our government put out this statement as part of the plan to how COVID-19 decisions were being made, which is analogous to traveling on a trail, that we're constantly making observations and redirections based on what we see in front of us, and constantly reevaluating so that we get somewhere safely, not quickly. And that was the guiding principle for how decisions were being made, as well as all of these other factors like health system capacity, transmission in tertiary care centers, cities, testing capacity, etc. So this is not a very helpful graphic from when you're sitting from a distance, but we were surveying community serving organizations like community nonprofits, community wellness centers, harvesting organizations to examine the impact of COVID-19 on the populations they're serving. And so a lot of our organizations reported they were accessing extra funding to help support communities during COVID, which was really positive, and none of it was enough. So yes, we got it. Yes, we need more. The ways in which our community organizations needed more support really pointed to sort of core chronic issues that were exacerbated by COVID and existed before, such as overcrowding and the need for more housing, the need for more program space, more and better relationships with our federal government for funding, etc. One of the things we observed right away was that people were spending more time on the land, especially in 2020 when we had like the best spring weather ever. We even actually got satellite maps of different communities to see if we could show geographically like that the trails, more trail patterns, compared to earlier years, because so many people were going out on the land. And as a result, more food was coming into the community. So more country food was being shared, more people out on the land. Every community had some people who were on leave because of COVID, who still had a salary, who were, basically like paid harvesters as families who were going out and coming back and sharing food. And so our community organizations observe this as well and observe the increase in food sharing as a result. This big red part of the pie chart is stress. Yes, we're feeling stressed, and stress and anxiety was a strong theme in all of the early research in COVID everywhere, but certainly in our communities as well. And in the last chart there, we were asking questions about violence because that was a concern among our community members. And so there were sort of like 50% said they thought they were observing more incidents of violence. Others felt differently. But basically what we saw was how our community was supporting, how everyone was supporting each other, and by sharing food, by watching out for our elders. Some of our stores and the post office instituted elder hours so that elders could go between 8 and 9 and they'd have that protected space where they wouldn't have to interact with anybody else. Which stayed for quite a while. People took other families out on the land and shared equipment and respected social distancing, and so there was very much a collective effort to protect one another and look after one another, and those are all very strong Inuit values, you know? So what we really saw was those Inuit values really coming up and bubbling up to the surface, where maybe our systems don't always allow that to happen, you know, on an everyday level. And so that was really exciting. We really wanted to document those strengths because the challenges are very much universal globally with COVID, but our community strengths really shone as well. And we really want to help tell that story. And so this is just my last slide before you wave me off. And so the ways in which our communities can support each other going forward. So, you know, we've made these observations through the pandemic, but now going forward, you know, what are we going to take away as learnings? And so our community organizations, you know, talk about, well, we need more education, we need more safe spaces for youth, we need to keep sharing country food, we need to keep prioritizing our elders and supporting local, you know, grassroots initiatives and more money and more. And so now there's a great motivation from all of the learnings through COVID to keep targeting those energies and those investments into community-driven initiatives and moving things forward. So very clear direction from our communities. And that's all from me. Thank you very much.
I think it is from Alaska, Katie Cueva. Dr. Katie Cueva. I will do this. You're on.
Well, thank you so much. It's so nice to be here and to be reunited with some of the folks from the Fulbright Arctic Initiative that I was a part of in 2017 through 2019. It's like a little family reunion here, so thank you for giving us this space to be able to do that. And this work started as we were in conversations with each other because of the Fulbright that we were a part of when the pandemic hit. And we began to speak about, well, what's happening where you are, what's happening in Greenland, what's happening in Iceland, and started to share different things that were happening in each of our regions. I'm from Alaska, so I was talking about things in that context and decided that we were going to put together some research on this to be able to look a little bit deeper on it. And I had the great privilege to be able to work with some fine people who are here in the audience, so thank you to Aya Guhluk, who's here and was really our lead on the ground for our work in Alaska, in Nunapachuk and in Bethel, and also Mallory Peterson, who's here, who flew to join us all the way from Montana and had a great outside perspective on what things look like here as compared to where she was. So in March 2020, we talked with people in 2 different communities in Alaska where I was born and grew up. And, oh, well, not that one. Let's try that again. Here we go. So here's a map of Alaska. And Anchorage is where I live and work, the land of the Dena'ina people, which you can see highlighted on the map, but a little bit farther west of that is what we call the Yukon-Kuskokwim region of Alaska. And where that red dot is, that marks Bethel, which is the hub community of that region. There's about 6,300 people there, so in Alaskan terms, it's huge. But I understand in other parts of the world, it may be considered a relatively small community. And in that region, there are several other smaller communities, 56 smaller communities in the region, one of which is Nunapachuk, and there's about 500 people there. And for both of these communities, the majority of residents are Alaska Native, Bethel has about a quarter of people who are white. It's because it's the hub. There's a more transient professional community that also lives and works there. People who are there for administrative and teaching, and there's a hospital there, doctors and nurses, things like that as well. But these are the two places we were able to work. So I also want to acknowledge that we were able to speak with a number of people in these places, and that's what this research is based on. This is our timeline of events at the beginning of the pandemic. So the state of Alaska suspended all non-essential medical appointments on March 19th in 2020. The pandemic arrived in Alaska in March 2020. However, you'll see that epi curve, this is the number of cases over time, but things stay relatively low through the summer. There were some things that the state of Alaska did kind of right off the bat, a travel ban, for example, that really helped keep our cases low, but a number of those bans were lifted. And so our first wave really hit that fall of 2020. So that blue line is cases in the state, which spikes quite a bit in the fall of 2020. And that orange line is cases in the Bethel region. And so in that census area, and it's a much smaller spike, but it's because there's fewer people there. So relatively speaking, it follows along with the trajectory of the state as a whole. Also, the boxes in green are tribal events that happened, like a storytelling event. The 1918-1919 Spanish flu was a large event in Alaska's history, and one which informed the way that communities responded to the pandemic. And the boxes in orange are things that happened in Bethel, so in that region. For example, the city of Bethel had a mask mandate, which was something that the state of Alaska chose not to do, but individual communities were able to make happen. I also wanted to give you some perspective on this. So this is the cases per day, is that top graph, from the beginning of the pandemic up through yesterday. So you can see that first spike was the largest one that we saw in the previous graph, that spike in the fall of 2020. Cases didn't go away after that, though, unfortunately, although there was some hope when the vaccine came out. But you can see that we had several other waves of cases, and things are ongoing. As Ayagutluk shared just this morning, Nunapachuk just lifted a lockdown yesterday, I believe. So there are still communities that are choosing to keep themselves safe by locking down even today. On the bottom are the deaths by month, and this is in the Bethel census area. So you can see that our mortality rate has really leveled off. So that's good news. Now, in Bethel and Nunapachuk, we spoke with people in groups and as individuals. We had 11 groups in Bethel, that hub community, and then 8 different groups in Nunapachuk, that smaller community in the region. And our central questions were really, how did the COVID-19 pandemic impact things for you and for your community? And how did your community respond? And we were really looking for strengths. You know, what is it that helped to keep your community safe? What were the barriers for allowing you to keep your community safe? We also asked a few questions about mental health and about policies. What was the impact of the different policies at those different levels, from the regional tribal health corporation to the city level to the national level, and how did they impact things in your community? And we talked to about 50 people, about half of them in Nunapachuk and about half in Bethel. We really focused on the indigenous community, so the Yupik people of the region. And we also focused on individuals who were elders. So you can see that our age range goes up to about 78 years old in Bethel. And Ayagutluk helped arrange all of these happenings with people and helped to recruit participants. So a huge thanks to him for making this happen. When we got our data, we wrote it down. We wrote down what people said. If they were in groups, we wrote it down on big pieces of flip chart paper so they could see what it was that we were taking away as researchers, and asked their permission for us to be able to use that in our research. And then Mallory and I both looked at those transcripts and coded them. So what is it that we think people are saying? We did that separately. And then we got together and said, you know, well, I think that they're talking about a disconnection from the land. Is that what you think that they're talking about? And when we had a difference, we made sure to discuss that so that we were really capturing what it was people were saying. And the main themes that we discovered from this were that people talked about a disconnection from relationships, a loosening of those familial ties. And in rural Alaska, our communities are small and they're very close-knit. So even when there's one death or one illness in a community, it can have a ripple effect on everyone in the community, especially when it's an elder, a culture bearer who has a lot of knowledge that they could be passing on that now they're not able to. People also talked about fear. They talked about depression, anxiety, and grief, as well as death. The COVID-19 pandemic disproportionately impacted Alaska Native people, much as in the United States, there is disproportionately high mortality rates among Indigenous people as a whole. However, there were positives as well. People talked about quarantine packages. So the CARES Act was used by the tribal corporations and the tribal organizations to provide food, provide cleaning supplies for people. They also hired quarantine workers, so people who delivered food, helped elders. So there's a lot of work done on the community level that was really positive. People also talked about working together, how the pandemic brought everyone closer and really highlighted some of those traditional relationships and traditional values. And I want to share a few quotes from the community members to allow them to speak for themselves. So that central theme of disconnection, so that's a disconnection between family and friends. One of the things that happened is where people were asked to stay apart from each other. And for close-knit communities, that can be quite a challenge, especially around times of a transition, such as a passing away, a death, or a funeral. And so in those instances, there was a large sense of loss that people were not able to pay their last respects to an individual. They had to choose between following through on that tradition or being mindful of COVID and following those protocols. Not being able to see people, not being able to maintain those ties and that sense of caring. Also talking about not being able to go see people in a hospital, which is true in many other places as well. However, these are some of the positive things as well, some of that working together. And just this morning, we were talking about, this connection to traditional Yupik values of compassion and also as service to others that really, I think, was highlighted by the people that we spoke to about sharing things, about sharing food, sharing whitefish, sharing moose, catching moose and distributing it to elders. Also, kind of a resurgence of traditional values with the fear and the threat of hospitals being overcrowded and individuals not being able to get health care if they needed it. People turned back to traditional medicine, and elders started to teach some of those practices again in case they were needed. And that was really a huge positive, so relying on each other, being kind to people. Also, that bottom quote about the city and the IRA is the tribal government in that community. Give me a second. And having two governments in a community can be quite a challenge. So that bottom one is about those two governance structures working together. And that is the end of that presentation.
I feel like the teacher. Next, we're going to call up Arja from Finland. Thank you.
I can also change here, I think so.
Yeah. You're good.
Yeah, okay. So it's great to be here. So thank you very much for this possibility to be in the panel and also having this great COVID-19 pandemic and public health workshop and having the results from the other areas in the Circumpolar North. So in this map, I will give you something about the Sami homeland, and so that you can see here is Finland, where I'm coming from, and we have Leena-Maria Nilsson, who is coming from Sweden. And unfortunately not we have anyone here from Norway. And actually this region here is Sami homeland, main area. And I think that many of the issues which I'm now telling is telling also the things which are happening in Norway and Sweden. And we have been, during this project, we have been working together so that, for example, in Sweden, it has been focusing more on the questionnaires, and in Norway, interviews and media analysis. And in our case, we have been focusing on the interviews and also making some media analysis. And our focus on municipalities, they have been the northernmost one, which are here in Utsjoki, which there's 1,300 people living, and the most biggest municipality is Inari, and there's around 7,000 inhabitants. And these two municipalities, they have the most Sami people, calculated as a percentage. And in our case, one issue was coming up, and it was the border restrictions. And usually this area is without any borders, so that people can just drive to cross the Tornio River from Finland to Sweden and back, and there's no one checking any passports or other. And the same is in Norway, so that there are 4 different places where you can cross the border and go work and having activities, and also the families, they are both sides of the borders. We have also one connection to Russia. So, during the corona time, the first case in Finland was in Saariselkä, which is in one of the tourist districts in Inari region. And it was the start of the corona pandemic actions. And in Finland, I think that the interviews which we made, it came also the information that it was a rather good thing, because they need to be prepared, and they were somehow more ready to go further during the pandemic time. Another issue which is, of course, very much impacted how the borders are going and working is how the national regulations and restrictions are. And in this article by the Andrei Petrov and others, so that they show that how the corona was taken in the restrictions in different Arctic countries. Greenland and Canada were very much closed, and then we have Faroe Islands, Iceland, Norway, and Finland, and we have much more strict policy and guidelines than compared to Sweden. And that was also the impact when we are thinking about the borders, how to do the things, and how the restrictions and guidelines, they were changing. And what is the status of our Sami homeland study and COVID-19? At the moment in Finland, we have made the data collection, interviews, and media review. We have made main analysis, and also the preliminary results, they are ready. And I can say that many of those which has been already said, working together, being in the nature, having the power in a new way, finding the new solutions in the municipalities, communities, and people are helping each other. And I think that they are also coming up very clearly, all in our 3 countries study in Sweden, Norway, and Finland. And this is one result from Sweden. As I already said, that in Sweden there were a questionnaire to Sami people who are living in the north from the Arctic Circle, and they were questionnaire. I think that there were 1,500 males and 2,000 females who answered after the two. In the middle of the, I think that it was Elena Maria is here, so that it was.
The entire Sami population in entire Sweden.
Okay, so so it was entire. Okay, so but it shows that when we are comparing the Sami prevalence of the COVID-19 infection, we can see that in total number and also the males and females, they are lower prevalence among Sami than the non-Sami in Sweden. I think that that was my last one, so thank you very much, and I'm happy to answer the questions. Thank you.
Oops, did that wrong. I'm supposed to do this. There we go. All right, thank you so much. And, oh, I forgot my glasses. Oh, okay, this one's going to be a little bit more on the feeling. Okay, no, take 1 second. I thought I could, I cannot. Oh, so I think we have Greenland next, so. There we go. And if I do this correctly, I got thrown off. Wonderful. Thank you.
Okay. Well, thank you so much, and thank you for the lovely introduction, Melody. It's really good to be here, and I'm happy to be able to share some of the results from Greenland. I will be co-presenting, although she's not here, with Inge-Lise Olesen, who is my partner and co-led the study, and Inge-Lise is the research coordinator at the Center for Public Health in Greenland, and we're based not only in Copenhagen, but also in Nuuk, in that beautiful black building that you see on the picture. So that's where a lot of this work was being done. And so this has already been mentioned in the previous presentations, but Greenland as well is a very close-knit community. One of the things that played an important part in the handling of COVID-19 was also limited resources. You only had that many doctors, that many hospital beds, that many test facilities, and so on. But also that it's a collectivistic society. It's people look out for each other, protect the elders, protect those at risk. So a lot of people were really happy when the country was shut down to protect everyone in the beginning of the pandemic, and I'll explain a little more about that. But one of the things that we also found in our study was that communication was really, both when it worked well, it was a strength, but also communication issues related to language, communication being done in Danish, but most people speaking Kalaallisut, Greenlandic, and so on. So, and what's so great about these days is that we get to discuss these results with everyone else here, and we're finding common themes, common inspiration for recommendations moving forward. So these are just some overall things. And for those of you who are not, Melody, you'll keep track of time, right? I'll look. Okay, good. So just to give you a little, some statistics about Greenland, about 80 communities, 64 of them are smaller communities, and the rest are larger communities. Most people, or percentage-wise, live in the capital of Nuuk, about 20,000 people. And then the second largest city has about 6,000 people it is actually now. And then, spread all over this huge, beautiful island. No roads connecting any communities. So you have to go, by plane or boat. And that, of course, has a huge impact on what's possible handling a public health crisis. So COVID-19 really entered Greenland on March 16. This is the Prime Minister at that time, Kim Kielsen. And then up until January 22nd, a very effective strategy almost kept COVID out, or at least when it came, we were able to control it. But by January 22nd, which is when Omicron came, there was nothing more to do. And then, we stopped testing, we stopped registering, we stopped tracing because we couldn't keep up. But the good part of that is that we did actually only had 21 deaths that were not necessarily caused by COVID, but that were COVID positive. So in that sense, we're lucky. So the phases, and these are defined by the chief medical officer, who's been, just, again, like working impressively hard since the beginning, as many others in this, but I keep being impressed every time that he engages in conversation and just keeps working. But the first phase was really when the virus came, and then Greenland was totally shut down, so you couldn't enter. And you can only go to Greenland by plane through Copenhagen in Denmark, so we were able to shut down the country. It opened up again in April, and then for about a year, the virus was controlled by you had to test negative before getting on the plane, and then when you arrived in Greenland, you quarantined for 5 days, and then you tested again, and then you were only allowed to go out. And that was a really efficient strategy. We didn't have the test facilities in the beginning, but that came. And then phase 3 was when we started to have spread around the larger cities. And phase 4, when Delta came, really challenged, and you had outbreaks in Nuuk and the second largest city, Sisimiut, that couldn't be stopped. And then Omicron came around December 21. And at that point, as I mentioned, just stopped tracing and testing. And at this point, we're still in the phase 6 that was from April last year. And then we still see cases, but no restrictions are in place, and it's not they closed all of the crisis, all the departments that were set up for that. So in total, we had 21 deaths, as I said, and throughout the whole period, few cases of hospitalization, and they were all manageable. And it's very much due to the fact that we were able to postpone the widespread until almost everyone had been vaccinated. And so we were both waiting, to make sure that Denmark would have the capacity to help, and then sort of postponing everything. But then at the end, when we came there, we were able to manage ourselves as well. So I want to share with you some quotes from the interviews that we did. And like Gwen explained, the model that they're working from at her research center, so are we working from a very holistic understanding of health. That's important. So we always start with values, relationships, context, honor, respect, things that are all key to Greenlandic Inuit culture. And this is illustrated by the framework that we work from. That very much is also something that Inge-Lise has worked and based on years and years of interviewing and conversation with community and elders, not least. So you'll have all of the classic determinants of health, like lifestyle and biology. But if you move around the circle, you'll see we'll have local values, culture and language, quality of life, family relationship, community, country food, which is Galalimanit, connection to nature and animals. And then what connects everything is the connection between body, mind, and spirit. So this was the framework that we used for engaging and having conversation with community members about COVID-19. And so I'll just give you some examples of what came out of that. So for example, when we look, and this is the Greenlandic, the word for community, when we look at the sense of community, it's the foundation for health and well-being. So that was illustrated, for example, by one of our community members who said, that's why I'm here so much. It's to get that sense of community. It means so much when we older people are physically active together. It was closed during Corona. You became very lonely and felt abandoned. And then another thing that really brings people together is bingo. So that was also brought up. Now it's different because of Corona. We couldn't go to bingo anymore. I'm so happy to go to bingo in the evening, but they asked me to leave because of Corona, because you could only sit 5 at a table. So that really disrupted how people were, normally getting that sense of community. And it's important for health and well-being. And these quotes show that I see health as the community relationship with others, around being happy, singing with others, activating each other. I feel healthy when I'm with other people, and I participate as much as possible in events here. It's not healthy to be lonely. Health in body and soul is being together in a community. And these quotes are not just relevant for COVID-19. This is really key to every public health issue. People were also stressing the importance of the food, of the Greenlandic food, Kalaalleq. We've had several conversations these days that food is medicine, and I mean, food has stories. Lena Maria is talking about it. Jim, you had points about that as well. And Pilineq is also you go on the land to collect the food. So it's quite common here, being in nature and hunting. There's no change in that. Being in nature, catching, preparing one's own catch. There's not been a change in that. We've always done that. There's no change of it because of Corona. And this quote came about because we were asking people, are you out on the land more? So for example, in a more Western context, there was a lot of discussion about people going out and, taking walks and having fresh air. But in a Greenlandic context, this is very normal. This is how you live life. This is how you're well with your family. So that was just speaking to that. But also to the country food. We may also be more resilient in North Greenland because of that we eat Kalaalleq. That may also be one of the reasons, at least that's what people say. So that feeling of being strong because of the food that you could harvest. There was some challenges in the cultural event as well, and people weren't able to meet, and you always gather when there's, any event really, like someone starts in school or there's a birthday, and people were really creative, sailed out and met and invited people anyway, and then people would just come in smaller portions. Am I out of time, Melody? Okay. All right. And so one last point was also to really pay attention to local values, both as a strength, but also as something that can sort of affect how, for example, vaccination coverage. So if someone in a community don't feel safe about the vaccine, or they do, we saw that very much affected the result of of how many people would get vaccinated. So local attitudes and the close relationship between everyone was something that came out as a really important issue in communication around COVID-19 as well. And I think I'll stop there. Qoyanak.
Thank you very much. I can already see how the days have been connecting so many dots as you meet together, and how important it is for you to meet together. Let's see. I will get to you. Let's see. Whoops. Getting there. And go. I think I did it. I did. Thank you, Dr.
Good afternoon, everyone. I'm really grateful to be here at Dartmouth again, and also for taking part in this project and reuniting with my Fulbright cohort, and also expanding my network. But I'm now going to talk about the research that was conducted in Iceland, and heading the team together with me was Dr. David Cook. And this is the Icelandic team, so we gathered students both on master's level, doctoral level, and a postdoc, helping us with this research. So the overall aim of the study was to identify and assess both positive and negative societal impacts associated with COVID-19 pandemic in Iceland, using municipalities in the Westfjords of Iceland as a case. And I will show you on map where this is. So the research questions that we asked focused on the public health measures implemented in general, but also community experiences with public health measures. We asked about coping strategies, the communities,
both in case of communities, but also individuals, and how they engaged to adapt to the pandemic. And then also because we don't have indigenous peoples in Iceland, we wanted to know also about the impacts on foreign people staying or living in Iceland and immigrants. And we have about 80% of the population in the Westfjords that are foreigners, mostly from Poland. So we wanted to explore that topic as well. And then learnings from the community case studies to inform policy and program implementation now and in the future. That was our main aim. So this is the map of Iceland, and this is the international airport in this area. We have the capital city here, and then we decided to focus on Westfjords. We were thinking to begin with, should we go even to this corner of the country or to the northeast or this part of Iceland, but the reason why we selected this area here as a case study is because of outbreaks early on during the pandemic, really severe incidents where we actually got infections into a retirement home or a nursing home. So this is just to highlight this area here. So we have the biggest town, Ísafjörður, but we also conducted interviews in Hnífsdalur, Bolungarvík, Flateyri. So we were focusing on this area here. And these are the waves, early waves in in Iceland. So they were hit really hard in these early waves. And this is when we started to screen cases at the border, the national border of Iceland. I also have a longer timeline actually showing that when we compare this to the overall situation for a longer period of time, these are really, really small waves. But since these are early waves, we didn't have much knowledge about the impact. And that is why it's critical to look at these waves here. So we conducted data collection in October 21, and we conducted 42 interviews, and we managed to talk to one of the town mayors, health authorities and healthcare workers, people within the education system, ranging from kindergarten to high schools, but also there is a university center in Westfjords with a lot of students and staff, mainly from abroad. So this is the part of the people that we interviewed, but also port authorities, because they are both critical in terms of both tourism and cruise ships, but also in terms of the fishing sector. And then we talked to immigrants from Poland working in Iceland, business owners, managers, law enforcement, civil protection, and emergency management, and others. And then we have transcribed and translated the interviews. Some of them were conducted most of them were conducted in English, some in Icelandic, but also a few in Polish with the help from a translator. So far, we have published 2 papers based on our findings. They are both in open access. One did focus on the COVID-19 and well-being in remote coastal communities. And since there was a lot of discussion about the businesses and impact from businesses, but also in terms of loss of jobs and these issues, we decided to focus on in the second paper on human resource management in terms of institutional resilience during the pandemic. And I'm just briefly going to introduce 2 frameworks that we used in those papers for our analysis. One, the well-being framework that we used is very much tied to the UN Sustainable Development Goals, and I just wanted to highlight this by showing this image here. But because you can see here in this image that how they relate, the framework that we use relate to the Sustainable Development Goals. But this was a well-being framework developed by David Cook and Brynhildur Davíðsdóttir. So it has 4 main categories, which are natural, social, human, financial, and physical capital assets, and focusing on, in terms of the natural environment, planetary physical boundaries, meaning the natural environment, and then in terms of the social aspect, meeting fundamental human needs, and by focusing on civil engagement and governance, cultural identity, social connections. In terms of the human capital assets, The focus was on human development, capacities and flourishing, and the domains within this category are health, knowledge and skills, time use, and subjective well-being. And the final category that we looked or used our data to compare with this framework was in terms of the financial and physical aspect, delivering a fair distribution of resources, income and wealth. So we looked, and a lot of themes came are in our data related to housing, income and consumption, jobs and earnings and so forth. So this was one of the analytical framework that we used for the first paper. For the second paper, we found this rather simple model that we used coming from Matt et al. In 2018, and it's about organizational resilience. And like if the organizations have had the capacity to anticipate the situation and plan accordingly, and then manage and survive and learn and growth. After analyzing our data through this framework, or using this framework, we decided that we would suggest an alteration to this framework because COVID came in different waves. So even though the institutions or the companies didn't anticipate the situation in the first wave, they were able to do so in the second wave. So we decided or suggested that actually there's a need to have the arrows in two directions. So because like when you are starting to manage and survive the situation through one of maybe the first wave, then you have a second wave and you have to go back to anticipate and plan accordingly. And then we also learned through our analysis that companies or institutions, they manage to adapt to the situation and in some cases even thrive. So that was our suggestion for improvements. So I have combined findings from paper 1 and 2. This one talks about the impacts. So the most discussed impacts of the pandemic were of social nature, such as the impact of social isolation and local gathering restrictions, such as have been mentioned by others as well. The concerns were displaced over the experience of youth and the elderly and the foreigners. So these were the three groups that people considered to be the most vulnerable members of the community. The size and isolations of the community produced challenges because didn't bring this up, but we are talking about a few thousand people living in total living in this area, some of the towns with a really small population. And there's also concerns over how the local health service could handle severe cases accompanying large outbreaks, because that was what the community experienced. And the pandemic brought both economic decline but also growth to various businesses. So we also saw some companies thrive. In terms of the coping strategies, to give you some examples, many of the coping strategies reported stemmed from the nature of the community itself. So the challenges were the size and the isolation of the community. It would, in some cases, it protected the society, but sometimes it was a risk factor. So easy access to high quality outdoor recreation, like hiking, skiing, and the ability to take socially distance walk with friends were examples of the positive benefits of being so isolated. Increased community resilience from experiences dealing with past disasters. So we have had avalanches, sea accidents and such in this area. So this was helping the community actually deal with situation because they have already dealt with other types of issues. Small size of community enables easy sharing of information between community members and easy access to the community on the part of the local planners, but also increased family time and remote working helped many to cope during the pandemic, though a lack of childcare combined with working and studying from home also provided challenges for some. And then in terms of foreign residents and immigrants in this area, there were, to begin with, insufficient information in foreign languages about the impacts of the pandemic and mandatory restrictions such as on gathering limits and mask wearing. So later on, they started to translate this also into other languages. So difficulties in rehousing infected foreign students at the local university center who lived in multi-occupancy properties due to the limited housing availability in the town of Ísafjörður and the lack of quarantine hotel. But we had such facilities in Reykjavik in the capital area. So this was not possible in this, so that this created a lot of problems for those operating the university center. Limited possibility to visit family and loved ones in home country, and that was the issue brought up by the foreigners that we discussed this with. And the last that I want to mention are the learnings. So business owners that managed to thrive during the crisis were those that successfully adapted their operations and proved flexible in the face of changing circumstances. We have many examples of this. And one of the things that we also draw as a learning from this is that national regulations, they do not always factor into the local circumstances. So sometimes there were no cases in Westfjords, but they had to follow the rules in the capital area or in the country as a whole, like a limited gathering of 20 people, but there were no cases there. But in other cases, they actually had to follow even stricter rules than the rest of the country. So you need to take the local situation into considerations. And this suggests a need for integrating flexible approaches to national mandates that's enabling local conditions to be considered. And then a clear national policy with a capacity for slight alterations on the local level could prove helpful in the future crisis. And what was beneficial in Iceland in general, but also in this area, was public trust in health authorities and the government, and respect for public officials responsible for setting Iceland's policy. It helps ensure compliance with the public health measures. The issue was mainly brought up in terms of the foreigners, the immigrants in Iceland, because to begin with, when they didn't have news in their own language, they did seek information from their home country, where the trust in the government was not the same, and there was a lot of misinformation in other groups than those that spoke Icelandic. And the increased remote work was viewed as a key development for the area as a whole to help the community go forward as a means of increasing opportunity for those living in remote areas, as well as minimizing the cost and time of always needing to go to Reykjavik for meetings, because this is also an issue in this area where you cannot fly every day, and there's a lot of bad weather conditions or whatever. So people don't usually have to fly the day before and go home the day after. So there was also a lot of time that they saved actually by being able to work from home. So this was my last slide. Thank you.
Thank you so much. We now have time. So again, I can see, I love from the very beginning of walking through the land and finding paths and understanding that that's really how we've had to deal with this crisis around the world. But I love the sense of how a community can see this about traveling across the land. I think this was the very first slide and understanding of picking your path and adapting as you go, to really then the structural. We need to adapt as we manage. I loved how that all came together in the end. I want to open up for people to have questions for this incredible panel from all the different perspectives we've seen and where they're going next. And I'm going to start with Lisa Adams. Dr. Lisa Adams, you wait for the microphone.
Well, thank you all for those really wonderful and condensed presentations. I'm sure there's a lot more that you could have said about the work that you've done, and congratulations on the really rigorous research that you've all completed. I was really interested in what was touched on a little bit in your last presentation, and Christina, you sort of touched on it too, recognizing that so much was able to be accomplished because of the community values and the community strengths. I'm also interested in that interface with the health sector, with the healthcare system and the public health service, because as you probably are well aware, that was a disastrous part of the U.S. COVID response in most of the U.S. And my CDC friend refers to us as having a bankruptcy of trust now. So I'm curious how having that collectivism, that community-focused approach, how that affected or not the interactions and the interface with the health and public health systems.
Okay. Yes. Is that directed at anyone in particular? Who would like to start? Do you want to go first? Katie's got ready.
Well, speaking of the country that we live in, so I would say that even though perhaps there's a bankruptcy of trust on a national level, I think when we look at the individual community level, there can be a lot, the situation can look quite different. For example, in Alaska, we not only have, of course, federal systems which came into play in the pandemic, things like the CARES Act and national leadership, which you're probably well aware of, but also there's tribal health systems. So in Alaska, there's IHS-funded institutions, as well as regional health corporations. In the area that we were working in, there's the Yukon-Kuskokwim Health Corporation, which translated kind of CDC-level mandates into that local regional context. But then I think a huge player was also the tribal village corporations. So there's a tribal council in Bethel that we had worked with, as well as a tribal council in Nunapachuk. And really that local level, I think, was where a lot of that trust was. And I think if you pass the microphone directly in front of you, Ayagutluk may be able to address that just a little bit as well.
Thank you. I believe the interface and communications shifted to local ways of understanding, not necessarily to meet and comply to something else that's in design. So in many of the communities, I believe, even though a village might lock down and stop people from commerce coming to pick up supplies from the local store, that had to happen despite the lockdowns. So, for example, if one community was close enough to another one with supplies they don't have in their community, they could easily get on their smartphone and place an order, get that filled, and they'd have COVID workers fill the order, bring it halfway across the trail on a frozen tundra trail, and have the order be picked up, no contact. So that's just one example of how integration maybe was adapted into existing commerce. So I hope that helps answer. Yes. Yes.
Jim, could you tell who you are? Because we have online participants and that makes sense.
I'm sorry?
Could you introduce yourself for online participants?
My name is Ayagutluk. I'm from the village of Nunapachuk in Alaska. One of the two communities our research connected with. And I'm currently living in Bethel, employed by YKHC Yukon-Kuskokwim Health Corporation, assisting with a wellness program where it pulls our cultural strengths into the content and adapting it into behavior health support and wellness. Thank you.
So the thing in Finland.
So in Finland, Norway, and Sweden, I think that they were big trust on the health professionals, and they were the same kind of the information coming out in many channels. And I think that, for example, Facebook was very good, but also the local newspaper and everything like that, so that different ways. And these two municipalities, Utsjoki and Inari, they were working together so that they sent the same information all the time.
Yeah, what I would like to add is how successful Iceland was in dealing with this situation, I think, is because those that were bringing the message to the population or the people were not policymakers. So we had a team of 3 people that were responsible for having almost daily meeting for months with bringing out information about the number of cases and how we were dealing with this. And this was the chief person in terms of, what is your epidemiologist? This is for me a really challenging word, but yeah, so we had like the chief of the person responsible for this crisis, but also the head of health authorities in Iceland, and also for civil protection and that type of taking care of the risk and how to actually protect the population. These were the key spokespeople that were bringing the message to the people, not the policymakers.
And then just a quick comment from Greenland as well. And the same actually, like all the messaging and all the communication was coming from our chief medical officer or health minister. We had several health ministers during COVID, and then also the chief of police. And so the health sector is very centralized in Greenland. So Minister of Health, Deputy Chief Minister, Chief Medical Officer, they were all meeting at a daily basis, and with the the directors of the whole health system in Greenland as well. And what came out of our study and the general impression overall was a high level of trust in that system, but also that the system delivered and people felt protected and were met. So I think that was probably even stronger at this point, but I think probably also related to the way so some of the issues that were some challenges with was more a language thing. So some of the communication was being done in Danish, and most people in Greenland speak Kalaallisut, the Greenlandic language, naturally, and so of course there are translations going, but it's like 2 language systems, so things weren't coming through, so there were some issues there that created frustration. So that came out in our study, but it wasn't about trust; it was more about communication. Yeah.
Just from the Nunavut perspective, because our territory is it's very large geographically and very small population-wise, so the Nunavut government was very open, communicating with people regularly and trying to reach them where they were, like through the radio, through Facebook, through live press conferences that we would all tune into at 11 a.m. every day, and then. But there was a greater understanding, I think, overall of the fact that we are working for them. Like these are my daughters. I just wish to acknowledge them in the audience, that are young and more vulnerable, and our elders, that just everybody was sort of coming with that lens that we are all working together to protect our most vulnerable. And so that means everyone has to work together. And so I think within the extent that they were able, our government was collaborating, and we have other studies on the impacts of COVID where community members say, we're really impressed with our healthcare staff, and so the community feedback was very strong. And then because Nunavut's created under a land claim within Canada, we have a territorial land claim organization called Nunavut Tungavik, and they were working collaboratively too to run extra vaccination clinics and help with other communication. And so everyone, really, it was just a spirit of everyone working together as much as possible.
Thank you all. I think we'll probably do about two more questions. I know one, and I'll get over there, one online that just came in was just, and it might be just a show of hands of a question from Janet Warburton, I believe, asking whether, did each of your spaces, did anyone actually have a vaccine mandate? Sort of yes or no, and was that part in this public trust? Was there a vaccine mandate in any of the countries? That's a no. All no's, I think. Well, it just says, did any of you have a vaccine mandate, I believe. So yes, I guess it's a national version. So, but no worries, we will move on that. It was a question that came in, but let me go next to Dawn.
Thank you so much for this today. One of the elements that we're struggling with in the United States is what the effects, long-term effects will be of the mental health issues that came up for different reasons. And each of you discussed that. You also, almost to a person, discussed about the resilience of your communities. And are you already seeing a bounce back? Is there any indication that there might be a change there that is not showing up yet in the United States? Are you getting any information on that yet? A change in anxiety levels or whatever other metrics you were using to measure the mental health state? Thank you.
Can I start, or do you want to? Okay. Well, just a quick comment that we don't have the data to answer that probably yet, but what we will do, we'll have a next public health survey starting next year. And so we'll try to address some of those issues, knowing that, we won't be able to measure any causal mechanisms, but at least trying to see if people are expressing any links on long-term causes there. And I know our chief medical officers more looking into what were some of the treatments that were not being done, right? And there were some pretty significant drops in levels of who went to the doctor and who got sent to Denmark for this and that check. And so I'm sure we'll see some long-term effects of that, looking into cancer and what that means as well. But it's super important, just we don't have the data to give a proper answer yet.
So I can say about the Sami health issue, so that the mental health clinics, they are in a Norwegian side, so that it was not possible to go, for example, from Sweden or Finland at the time when the borders were closed. And because of the history of Finland, we have the earlier time when it was not possible to go to the neighboring countries, Norway and Sweden. It was in the Second World War. And that's why the people who remember that time and feeling it has a huge stress, because it has been open land. And I think that kind of stressful issues have been in mind, and of course later on coming out other things also.
Yeah, we don't have additional data on this, but I think actually the time when we conducted the data, like a year and a half after we got the first wave, was really critical point in time, because then there was some distance from when this happened, but still people remembered what was happening. So the timing of the data collection, I think, was critical. In terms of the mandate, there was no mandate, but there was a lot of encouragement that people would show up for vaccination. And they had this huge concert hall or a handball, like a hall, sports hall, where people went to get the vaccination. And you felt like you were going to a rock concert when you went there. But there was a lot of encouragement, but no mandate on this.
In terms of what we've learned about mental health, I think what we learned in the early years of the pandemic was just the fear and anxiety around death and dying and for loved ones. And now it's the mental health issues that people bring up are more concern for the state of things now. So the loss of, education opportunities through, due to the disruptions in schooling. So one community member shared their concern about they have a child who's now in 3rd grade who would have entered kindergarten during COVID in the beginning and who still is just learning how to read. So things like that they're concerned about children not, progressing in school the same way it would have happened before COVID. And then, of course, we're still experiencing so much healthcare system stress. So especially for us in Nunavut, where we do have a reliance in our healthcare system on locum healthcare providers, so nurses and physicians who will come in and out, they're not coming as frequently because they're being stressed by what's happening in southern Canada. And so last summer there were some health centers that were only staffed by paramedics for emergencies only, like that would normally have nurses available all the time. And so that it's a different kind of stress that people are talking about now in mental health. And as Christina said, we're still just learning more, like we're still learning.
I think to echo my colleagues, that's not something that I think we're really readily able to answer at this point because, it's a long-term question, right? I think in Alaska, we're still responding actively to the pandemic. Communities are still locking down and are still making that choice when the cases reach a certain threshold. There's still a lot of active cases, even though we're not testing as much as we used to. So it is ongoing, and because of that, it's not something yet that we're able to say, well, now that it's over, because we're not there yet. But we shall see. Ask us again in a few years.
That means we have to come back.
Well, that is the perfect segue, because I was going to say, this is what you've just heard so much of is data being gathered, data being assimilated in the last of a recent pandemic. But really, this is the kind of knowledge. It's the knowledge across cultures, it's the knowledge across systems that we need as we move forward. And we are going to have the Lancet Commission on Arctic Health coming out soon that started before the pandemic, but obviously had to think about it, work during the pandemic. We have this incredible group now that I don't think they're going to disband from what I'm hearing. I think they can't disband. And so they're going to be looking at this now long term from so many different perspectives. And I do hope that Dartmouth will be a place that you can come back and tell us more about as you see this move. The look at the question online, it did say, what about vaccine mandates, both the country and community level? So these are kinds of questions I'm sure your report is going to be talking about as well. It sounds like what I'm seeing is there's so much eagerness for this knowledge and the way you're presenting it and really coming at this holistically. And again, very honored to have you. We hope you'll come back. And we know you're going to meet with students tomorrow. You're going to see more of Dartmouth in our snowiness. And I guess, is it raining now? I've heard it might be raining. I'm so sorry. But at least it was beautifully snowy and Arctic-like. So thank you again to all of you for being here. Thank you for the rest of the workshop participants. And I hope you have a wonderful third day and safe travels home. Thank you everyone for being here. And we will hope to see you again very soon. Take care.